Everyone. This is a lecture on musculoskeletal assessment. This will be the last lecture to go for exam number 2. So let's move on. Okay, so your musculoskeletal assessment will include your posture, gait, cerebral function, bone structure, muscle strength, joint mobility, and ability to perform ADLs. Remember, your musculoskeletal system provides shape and support to the body, allows movement, protects internal organs. Think of your rib cages, your skull, produces red blood cells in the bone marrow, homeostasis, I know I said that wrong, homeopoiesis, and stores calcium and phosphorus in the bone, so there's many things. And as you'll see as we go along, like here with cerebellar function, gait, strength, your musculoskeletal neurological system work together. So your assessments can be blended. Some in assessing posture, you want the healthy posture. You can see the shoulder and the hip should be lined. It should be shoulder, hip bone, ankle bone. Should come down the side. That is good posture for supporting the spine. There are terms lordosis, kyphosis, scoliosis. On the last slide on terms, I defined those, but lordosis is in your lumbar. Kyphosis is the thoracic or hump, and scoliosis is that curvature, some might call an S shape. Some will cause, as you can see, like here, a forward tilt. Sometimes this causes a more backward tilt of the head. Okay. This is just to help you when you do your musculoskeletal assessment in the lab. We'll talk more on this, but you can see we're not going to be doing measurements of muscles and leg length and all those things. But if you did, you can see here this curvature can be multiple degrees, can be in multiple directions, and we'll practice on each other actually feeling down the spinal cord. You have the person bend forward in front of you, you actually visualize the spine and palpate all the way down for the curve. Bulges, tenderness, multiple things. This is a picture of what some refer to as senile kyphosis, that hump, as you get more compression in here, losing disc space, losing muscle strength, and humping over or senile kyphosis. There's multiple different gaits. I don't expect you to remember all of them. I picked out ones I feel are most significant that cover your antalgic gait. I don't have a picture of that one here, but that's that person that does that to avoid pain. Often like if a knee or a hip where they're pulling off of that joint because of the pain. Ataxic. I'm looking at these pictures. Your ataxic is what I would refer to as your drunk walk. It lacks balance, uncoordinated, or unsteady. It can be due to poor sensation or a lack of muscle control, which might be neurological. It can be jerky or weaving. It's an ataxic gait. Hemiplegic gait is where one side is weak or paralyzed, kind of dragging through that side. Parkinsonian, I think it used to be called a propulsive gait. It's a rapid shuffling gait with a rigid, stooped posture. It's that one right here. I think this is, I'm trying to read that if that's here. Hemiplegic, yes. Favoring that side, usually after like a stroke, one side is weak or paralyzed. You have your scissor gait, where one foot crosses in front of the other. It's more like a spastic paresis of the legs, where they have to jerk it forward. And a steppage, Might be something. I'm trying to see this here. That's a sensory ataxia, where it's so hypersensitive. They pull their foot off when it hits the ground, and then this is usually like a foot drop instead of the heel hitting the ground first, because when you step, you should hit the heel first. So, but they go on the toe first, like a foot drop due to a muscle loss or weakness in there. And steppage is a high step where the foot, high step for the foot to kind of clear the ground. They look like they're prancing, like a horse prance. We've worked on cerebellar function, doing neuro assessment. We're expanding here into the musculoskeletal. You'll see where those two cross over. You can do your balance with the heel toe as pictured here. There's also, you have them walk on their toes and then walk on their heels. Romberg, some people have them put their arms out, but that's not necessary. They stand with their arms usually to the side. Some will have them put their arms out first with their eyes open, have them close their eyes, and give them like 30 seconds to see if they lose their balance. This picture has somebody arms in front and behind, not actually touching them in case their balance goes off and they fall backward or forward. That's a cerebellar neurological issue. Coordination, we did do the finger to the nose, the finger to the examiner's hand. We also tapped our fingers, coordinating that way. You can do the hands prone and supine, flipping over. What's another? Tapping the toe on the ground. Multiple things to check coordination. Bone structure and muscle strength. You can't really do one. Bone structure is palpating wherever they're painful. Sometimes you can feel nodules, large things, fluid, crepitus, different things when we go over terminology and checking your muscle strength, muscle movement. You're looking for symmetry. So as these pictures show, you always do both sides at the same time. There's multiple areas. We did it where you put your hands next to the face and pushed against for muscle strength there with your cranial nerves and shrugging your shoulders, pushing against that way. You can have them squeeze your fingers. Sorry, I shouldn't have picked that picture. You always want to do two fingers from the bottom. Give them two fingers in each hand. Come from the underside of the hand, from their pinky side. Otherwise, they can grip you a little too hard. That way, you're safe. Have them push both your feet down, especially if they're laying in the bed. You just have them push against your feet, squeeze their hands, bend their arms, and pull against you. Always looking for symmetrical strength, if one side's weaker than the other. Okay, this is terminology that I'm sure you've seen before. I did not put it on the term slide, but you do need to know these. I just didn't see repeating them. For range of motion, you want to check the range of motion of the different joints, especially if there's a particular joint they have pain in. So your range of motion, depression is lowering the body, elevation is elevating. So bringing chin to chest is depression. Raising the chin up is elevation. Protraction is moving forward, putting chin out or neck out. Retraction is pull it backward, retracting. Let's see, pronation, supination, turning. Pronation is turning downward. Supination is turning upward. I had somebody say once, with supination, think of making your hand into a bowl of soup. So supination is up, pronation is down. Inversion is turning the toes inward, and eversion is turning them outward. It goes for the wrist, both the wrist and the ankles. Extension going out, flexion coming forward. The neck gets confusing that way, but if you think of your cervical spine is where your joints are. So when you extend the cervical spine, you bring your chin forward, that spine extends. When you bring your neck backward, those joints are compressing, so that's your flexion. Your hips, you're doing internal and external rotation, and abduction, adduction with your arms and with your legs. You're adding to it, bringing them in. Abduction, you're bringing it out. Same thing with the arm, bringing the arm to the body is adduction, out from the body is abduction. Seems like I'm forgetting something. It says circumduction with the arm. That's the picture. Picture is what threw me off. We're taking your shoulder, because your shoulder goes all the way around, so it's taking it through its full range of motion of the shoulder. Or circumduction. I think it's circumventing, going around the whole, like the drain. Anyway. Okay, so your activities of daily living. I did this picture to help you think of the questions you would ask, the things you would assess for your activities of daily living. Your eating, bathing, dressing, transferring, toileting, walking, moving around. Those are the questions on your health history, on your assessment. If you were asked to do a functional assessment, that's what I'm looking for. So be able to be prepared how to do that assessment, what questions you would ask. Subjective data. Your joints, joint issues, any problems with your joint? Do you have pain? Which joint is it in? How long has it been there? Is it on one side, both sides? The quality, how does the pain feel? Is it aching, stiff, sharp, dull, shooting, severity? How long has it been there? Does it limit you? Your muscles, you're asking about muscle pain, muscle strength, weakness, atrophy, injuries to them, bone issues, injuries, pain, complications, surgeries, fractures, activities of daily living and functioning, so bathing, toileting, dressing, grooming, eating, mobility. Also, your functioning is your ability to communicate, your speech, cognitive, being able to respond. Self-care. What is their occupation? Is there environmental exposure? Do they get exercise? What kind of exercise? Are they obese? Hormones, problems with their bone, like with calcium, bone disorders. With the elderly, you're always assessing their safety. Some more terms other than the ones that were on slide 8 on your range of motion is ataxia, which I mentioned on the gait, which is an inability to perform coordinated movements. Bursa is an enclosed sac filled with viscous fluid in the joint area. It helps prevent friction, so you might see a bursitis or inflammation of the bursa in the shoulder as a diagnosis. Crepitation is a dry, crackling sound or sensation at the ends of damaged bones. A lot of times when there's an injury on a joint, you'll feel a crepitation around the knee. I always call it a feeling like Rice Krispies. That's what it feels like under my fingers. Dorsa, directed toward or located on the surface, the dorsum or dorsal. Kyphosis, recovered in the spine, which is outward or convex curvature of the thoracic spine. Your ligament is a fibrous band that connects bone to bone, whereas down here your tendon attaches muscle to bone. Ligament, bone to bone, tendon, muscle to bone. Plantar, the opposite of dorsa. Plantar is the surface of the sole of the foot, where you think of checking pulses on the dorsa or surface of the foot, not the plantar side. You will get your dorsalis pedis pulse. That's dorsalis. It's on the dorsal surface pedal of the foot. Range of motion is the extent of movement of a joint. Scoliosis is the S-shaped curvature, usually the thoracic. It can sometimes go down into the lumbar. And I already told you tendon, which is your muscle to bone. And that actually covers everything for musculoskeletal. I will see you in class.